Okay, you guys can catch up when you log in later. Okay, here we go. There's 20 questions for this one. Okay, what are Langerhans cells? So provide a screen against potentially harmful UV rays. What cells do that? Melanocytes. So we know it can't be that one. Then we're left with three more. We got a lot of time here, but yeah. Langerhans is the immunity part of the skin, antigen presenting cells to the white blood cells to take care of. Okay, how would you describe a 5 millimeter size non-palpable area of decreased pigmentation? So when you're studying all those images, make sure you know the small version and the larger version. Make sure you know what the cutoff is. Most of them are 1 centimeters in size. So this one is a macule. The patch is the bigger version of the macule. Okay, 45-year-old female complaining of rough and thickened skin resembling tree bark. Okay. So looking at the answers, yellow, acne vulgaris. Obviously everyone knows what acne is. It does not present as rough, thickened skin, so we know we can get rid of that one. Erythema nodosum, what's special about that one? What? They're red, brown, but they're very deep in the fat layer. So erythema nodosum will be red, black, brown spots. Remember, erythema nodosum affects the fat, subcutaneous fat. That's why it's very deep. There's no clear borders or anything. Disseminated histoplasmosis, we never even mentioned it once in this class, so it cannot be an answer. Never mentioned it once. So, like I said, and those of you who do Quizlets, making that fourth answer is very tough sometimes, so I just find random stuff and throw it in there, just to get the fourth answer. But if I've ever mentioned a word in class, it's not going to be an answer. Okay, what's the major difference between a vesicle and a pustule? Contents, what's inside of it? Okay, so that's what matters between a vesicle and a pustule. What does demarcation refer to? The border, the line around it, very crisp line around it, line of demarcation. So it's the contents is what matters. Okay, 65-year-old male, chronic alcoholism. You notice spider-like blood vessels on the nose. What are those spider-like vessels known as? Okay, very good. This is telangiectasias. Okay. 23-year-old female, petechial rash on her face. She was drunk at UF game night before. What's the cause? Horrible football? No. Okay. So, now, I did put other things on here though. So, looking at the wrong answers, reaction to a new detergent. What kind of reaction would they have? Would it be like a petechial? First of all, what is petechiae? Little, tiny little dots from ruptured capillaries, essentially. So it's from the vomiting. Reaction to new detergent, they would have a rash over the entire body, wherever that skin came in contact with the clothes. Bruise, purpura. Remember that as you get petechiae get bigger, it's called ecchymosis, which is the bruise. The bigger bruise is ecchymosis. Reaction from spray tan would be something different. It's just a spray. It'd be like an allergic dermatitis. Wherever you sprayed it would have the reaction, not anywhere else. Okay, which of the following diagnosis is an example of spongiotic dermatitis? So with spongiotic, remember it's going to have filling of fluid. Okay, obviously no one studied these 9, so I know that. So when you guys study, you make sure you know what 9 inflammatory processes are and what diseases go along with it. You may get a question. Most of them are just straightforward, like what is this, what is that, what is that? Then you have some other ones that make you think, of course. This one is your allergic contact dermatitis. Psoriasis is psoriasiform, very easy to remember. And then the other ones, make sure you study. Okay, which of the following is also seen in sarcoidosis? So what dermatologic manifestation does sarcoid also get? Okay, what's this one? This is your erythema nodosum. Seen with sarcoid, they get those, again, those deep red, brown signs on their skin. So remember, sarcoid goes with erythema nodosum. Okay, 66-year-old African-American male with bilateral hilar lymphadenopathy. On chest x-ray, also has a fever, arthralgias, and uveitis. What's the diagnosis? Again, if you didn't study, you're not going to know this one, but take a guess. But go backwards, work backwards if you don't know. If you know something else. So folliculitis, that's just like, irritation from shaving against the grain, you get the ingrown hair, that folliculitis, that's what that is. So we know it's not that. So Lofgren syndrome is this one. Make sure you know the difference between lupus pernio and Lofgren's. Both of them go together with regards to those granulomas on the nares. So make sure you read through all those and study those. 15-year-old acne vulgaris, you tell him to stop popping his pimples because what kind of reaction can that cause? So the blue and the yellow are pretty much the same thing, right? Your accumulation of keratin inside the plug or accumulation of shed keratin and sebum, which is the oil inside the plug. Rupture of lobular flat fat is not the answer. Obviously, secondary reaction, you're causing all those inflammatory products that are stuck inside the plug. Now you're breaking it by popping it, and those reactants spread to the surrounding tissue, cause secondary reactions nearby. Okay, what antibodies are produced in response to an allergen in atopy? So remember what atopy is referring to, work backwards, and what antibody is going to be produced. So what is atopy? Allergies. So what kind of reaction is it going to be? Hypersensitivity, type 1, and IgE. IgE goes with your allergies. Okay, during an asthma attack, what would a lung perfusion VQ scan show? Asthma attacks. So we're having problem with breathing or perfusion? Just pick simple numbers, like 10 over 2 is 5, but 10 over 5 is 2. So what's going on with the number? Go from there. Okay, going to go lower. Okay. So make sure you know VQs as far as when they go high, when do they go low. Okay, what's the major difference between chronic bronchitis and emphysema? Okay, so what's the major difference? Coughing. Why? What's coughing up? Who's coughing up what?
The bronchitis is coughing up they don't have the cilia anymore.
We lose, remember, in chronic bronchitis, they lose the ciliated cells, they lose the cilia, a lot of mucus production. They're always trying to clear their lungs and coughing all the time. Emphysema has no mucus production, so no cough. Okay? Okay, what's the driving force for polycythemia in a patient with chronic bronchitis? So why do they have polycythemia? What's the driving force that causes that to happen? What's the problem with chronic bronchitis? What is being affected with all that mucus?
I'm trying to think of what the word is. It's the gas exchange.
Diffusion, right? Diffusion distance goes up. So gas exchange is altered, so they become hypoxic. And remember the O2 tension in the kidneys, they're going to sense that low O2 tension and they're going to start pumping out EPO to make more red blood cells. But the red blood cells is not the problem. The problem is gas exchange with chronic bronchitis. So they're a hypoxic environment due to the lungs, not due to red blood cells. So when we talk about anemia, anemia is lack of red blood cells. Therefore, our O2 carrying capacity goes down, becoming hypoxic. But in chronic bronchitis, the issue is diffusion goes down, less oxygen going into the blood, becoming hypoxic, kidneys sense it, EPO, red blood cells go up, but we don't have a problem with red blood cells and become polycythemia with too much red blood cells. 65-year-old male, 20-pack-year history of smoking, O2 stats 86%, chest x-ray shows hyperinflation with a flat diaphragm. So there's two things. Obviously, we know smoking is the problem, emphysema or chronic bronchitis. The key is the x-ray, that what this is showing. So emphysematic patients or chronic bronchitis patients, who has that type of chest x-ray? Okay, emphysema, very, very good. Now, if this was acute CHF, what kind of things would you probably would be mentioning on that chest x-ray? Fluid backup, right? You see congestion, pulmonary edema, because if it's heart failure, you're going to have, remember, increased hydrostatic pressure in the pulmonary vasculature. It's going to dump out fluid into the lungs. So you would see that on an x-ray. You would see pulmonary edema. You would see something about that. Chronic bronchitis, they have what's called those tram track lines from the increased pulmonary vasculature or congestion. So on chronic bronchitis, they'll have tram track lines. Emphysema, hyperinflation with a flat diaphragm. Pulmonary embolism. Pulmonary embolism is looking at what? blood, not air. So with pulmonary embolism, if you had a PE, do you think you would see anything on an x-ray? No, because it doesn't look at blood on an x-ray, it looks at bone. If you use contrast, then yes. And the definitive way to find out if you have a pulmonary embolism is a CT scan with contrast, because we're looking at the contrast of in the blood. Wherever that goes, it'll glow under a camera. The problem with contrast is what? Allergy to the contrast, and there's another reason why you have to be very careful with contrast. Kidney function. So if someone comes in and you think they have a PE, but they're a chronic kidney patient, you can't give them contrast. That's when you do that VQ scan, which only uses nuclear medicine. It doesn't do anything with contrast or anything. So you give them that. CT angio is the gold standard for PE, though. That's the way to do it. Okay, moving along. 16, which of the following will you see with pulmonary hypertension? Okay. So pulmonary hypertension, is that going to affect the left or the right side of the heart? Left or the right? Right side of the heart, because the right side is pumping into the lungs. And if you already have pulmonary hypertension, we're increasing the afterload on that right ventricle. So the problems we're going to see are right-sided lesion, right-sided heart failure. So does pulmonary hypertension cause left-sided heart failure? No. Does pulmonary hypertension cause displacement of that PMI laterally? If you displace the PMI laterally, what chamber are you talking about? Left ventricle. We're dealing with the right side. This is pulmonary hypertension. It can't be yellow because the left ventricle is fine. Decrease right-sided pressures. It's going to be increased. That's the whole problem with pulmonary hypertension. It's increasing the pressures on that right ventricle. They don't like it. The normal pressure in the right ventricle is like 40 over 5, 40 over 10. Very, very, very low. That's the right ventricle pressure. Left ventricle is 120, 140, 150 over 80, 90, whatever that is. Right side pressures are very low. They don't like it. The minute they get high pressures, you get signs and symptoms of right-sided heart failure. So pulmonary hypertension, they get these plexiform lesions on the chest x-ray. So a plexiform lesion is going to be pulmonary hypertension. Okay, which of the following is an acute cause of cor pulmonale? So cor pulmonale, remember, are right-sided heart problems due to the lungs. Nothing to do with the heart. Now we're looking at acute causes. Which of those is an acute cause? And I'll give you your answer. Not all of them. Okay. Acute cause. Pulmonary hypertension is not acute. It takes years to develop. It doesn't happen overnight. Pulmonary interstitial fibrosis takes years and years to develop. If you have that disease, what type of pattern of lung disease will you have? Restrictive or obstructive? This is your restrictive diseases. Pulmonary interstitial fibrosis are part of your restrictive diseases. What kind of pattern will you see on biopsy of those tissues of the lungs? Honeycomb pattern. Okay, popping little holes. Chronic pulmonary emboli, it's got chronic in the word, it can't be chronic. And a massive pulmonary embolism would be an acute cause of cor pulmonale. You have a clot in the leg, it breaks off, goes into the lungs, causes a massive PE, that will be an acute cause. Make sure you guys, when you're reading these questions and you're studying, really differentiate what's an acute cause for a problem, what's a chronic cause. Go back to like the aortic stenosis question we had last time. Okay, depending on the age of that patient will tell you what caused their issues. Certain things don't happen early in life versus some things do happen later in life. So as you're starting to learn all these diseases, really focus on like, That's why we go over the etiology first. What happens, who gets it, what are the most common risk factors for these type of things. So keep those in mind too, acute versus chronic. Okay, someone inhaled irritant gases and now has pulmonary edema. Okay, so there's that one slide I had that had normal, and then it had like different damages to either the capillary wall or the alveolar wall that will cause problems. So we're inhaling irritant gases. So we're inhaling them. Where are they going to go? Into the lungs. So where are they going to damage? So pulmonary edema due to increased hydrostatic pressure. What kind of edema would that be? Those are cardiogenic, caused by the heart, hydrostatic pressure. What happened to the pause here? No, okay. Just took a long time for this one. Give you guys more time. Increased oncotic pressure. Okay, that would be something totally different. That would do it. Would increased oncotic pressure cause edema? Or resist edema, it's pulling. Okay, epithelial damage to the capillaries. When you inhale irritant gases, so when you're reading that slide, make sure you know some of them are endothelial damage, some of them are epithelial damage, and they give you examples of what will cause each one for your pulmonary edema. Okay, you perform a thoracentesis, which is when you put a needle into the space in the pleural space and you pull fluid out. So we're pulling out a fluid. It could be a transudate, it could be an exudate, but I'm telling you in the question that you note increased protein in that fluid. So increased protein, is that going to be an exudate or a transudate? That's an exudate. So now that I know that an exudate, which of those goes along with what an exudate will be? Malignancies. So remember, whenever you see an exudate, think cancer, something wrong is going on. Cirrhosis, nephrotic syndrome, hypoalbuminemia. Yes, they will cause fluid overload as well, but it's going to be a transudate. Mainly just water in there. With the other three. Malignancies will have the protein in there. So make sure you understand between transudate versus exudates. Okay, extended bed rest, cigarette smoking, recent surgery can result in what? Make sure you read the answers on this one, because it does matter in the order. It can't go the other way. It only goes one direction. These three things are all risk factors, and they're a triad. What's the triad called? Virchow's triad. Okay, Virchow's triad. Extended bed rest is immobility. Cigarette smoking, hypercoagulable state, so increased clotting, also vascular damage, and recent surgery, also vessel damage as well. Okay, and that is it for the Kahoot today. I'll post the link later on. You guys can do whatever you want with it. And now let me just pull up the case studies. Okay, let me do it on the other one. We're good now. Okay, the case studies are posted in Canvas as well, so if you want to follow along, you can. Okay. Okay. So moving on to our case studies. So first case, 61-year-old man presents to family practice complaining of 5 months, mild cough, increasing dyspnea on exertion. So obviously he's progressing, he's getting worse. With his breathing, no chest pain, no fevers, but states his sputum is frothy and sometimes looks pink. History of MI 2 years ago. So the fact that he had an MI 2 years ago means obviously this guy has heart problems. Physical exam, crackles, and rhonchi. What does that mean? Fluid. So he's got fluid in the lungs. Okay? And it's getting worse, which means the fluid is probably getting worse as well. So when we talk about pulmonary edema, what kind of pulmonary edema do you think this is based off of whatever the history I gave you was? I would say everything was cardiac. So it's probably a cardiac cause for the pulmonary edema, cardiogenic. What are the typical causes of this type of edema? So how do you get cardiogenic edema? Obviously the heart's not pumping very well. So we get buildup of blood, which increases what type of pressure? Your hydrostatic pressure, pushing fluid out into the lungs. So the LV failure, CHF, pulmonary hypertension will cause this type of edema. Why do they get pink, frothy sputum? Why is it pink? Blood. Okay, all that increased hydrostatic pressure bursts those very tiny, small capillaries. They bleed into the lungs, and you cough them out, and it mixed with the sputum. So pink, frothy sputum. Okay, capillary hemorrhage. Case 2. 35-year-old woman presents to the ER with shortness of breath. Long-standing history of anxiety. She takes oral contraceptive pills, and she smokes 1 pack of cigarettes per day. Both of those things will increase their risk of what? Smoking and oral contraceptives will increase risk for clots. Okay? Physical exam, heart rate is 120. Is that fast, slow, normal? Fast, so she's tachycardic. Respirations increase, she's tachypnic, so she's breathing fast. Her heart rate is fast. Lungs are clear, but you notice edema and erythema in the right lower extremity. Okay, already by now you can put the pieces together. One leg that's swollen and red. Shortness of breath. Obviously, she's setting the stage for a... Now, what's the diagnosis? Is there more than one? And this goes back to that Kahoot question when I said the order matters. So this is A. PE, DVT. So the way you would write this would be PE secondary to DVT. Because the DVT caused the PE. We know what the reason is. You can't have a PE that causes a DVT. Now I'm saying it starts in opposite directions. The clot starts in the legs and it goes along blood flow. Blood flow comes back to the heart through the lungs. So that's why it has to be a DVT first and then the PE. What is the pathophysiology behind the tachypnea and the hyperventilation? What is going on with a massive PE? Obstruction of what? Air or blood? Blood. So we have a perfusion problem. Okay, our ventilation is fine, but there's no perfusion going on because of this massive PE. So what is going to happen to our O2 concentration? Got to go down. What does she have here? Oh, I have that. I was on the air one. Okay, so they're going to become hypoxic. How do you correct hypoxia? You breathe more. Heart rate goes up to deliver more oxygen to those areas. Also, increase CO2 from that blocked perfusion, no gas exchange. So yes, hypoxia is very important, but also we're not getting rid of CO2 either. So CO2 starts to build up. That also is going to cause hyperventilation to try and blow off that CO2 from the acidity that's building up. So that's what a PE is. And what were the risk factors that she had? Smoking, oral contraceptive pills were the two big ones. Yes?
You just recommend her not go on. I know smoking is probably the bigger risk factor, but
She probably has to switch a different oral pill. So smoking and the oral contraceptives. Do you have a question, Christy? Okay, that's great. Next case, 66-year-old male, come to the ER complaining of shortness of breath, cough with sputum. Okay, so he's productive. When you see sputum, think, okay, is there something going on, an infection, what are you trying to clear or whatever? That's where your first goes. But then I tell you he's got no fevers. So maybe not an infection because he may have a fever with that. 2-pack per day smoking history, BMI is 32. Blue tinge around his lips and face. Mild distress, also has 2+ pitting edema in his bilateral lower extremities. So what are some key things here kind of leading you to where you think this case is going? So we have a breathing problem. He's got smoking. He's got a cough with production. Blue tinge around his lips and face. What does that mean if they're blue there? Hypoxic. Okay. Also has swelling in the extremities. So what do you think this one is? This is your chronic bronchitis. And what is going on with the edema? Chronic airway injury narrowing, has inflammation. Remember, the ciliated epithelium are replaced by the squamous one. Can't remove the mucus. Walls thicken. Smooth muscle proliferates. Mucus plugs are there, causing air to get stuck in the lungs. It can't let it get out. That's the obstruction. Causes decrease in air exchange, causing the end result is this hypoxic pulmonary vasoconstriction. Okay, so we're getting congested through the lungs, and that gives you that tram track line. Results in pulmonary hypertension, cor pulmonale, then eventually right-sided heart failure, because the cor pulmonale is going to affect the right side, and then you get your right-sided heart failure symptoms, lower extremity swelling, all because of the lungs getting backed up with all that mucus. So that's the link between chronic bronchitis and the signs and symptoms of heart failure. Again, untreated chronic bronchitis. If you catch it early and you treat it, you'll prevent the pulmonary hypertension from developing and the right-sided heart failure. And what are the main differences between bronchitis and emphysema? Smoking is one of, the smoking, they both smoke. The coughing is one of them. Remember, bronchitis is an airway disease. It's a disease of the airways. Emphysema is a disease of the tissue, the parenchyma, the lung tissue itself. Yes?
It's not like characteristic, but could you see like a skinny person with bronchitis and then like
Yeah, but the blue bloating is having with untreated, long-term, untreated chronic bronchitis. I'm sure they could present normal size shape too in their early stages. Okay, next one. 21-year-old male presents to the ER complaining of shortness of breath, has seasonal allergies and is allergic to smoke. His roommate smokes. He thinks he's ran out of his albuterol last week. Hunched over, monitor stress. Physical exam of the lungs reveal inspiratory and expiratory wheezes in all lung fields. Pulse ox is 90% on room air. We all know where this one's going, right? What is it? Asthma. We know what the trigger is, right? The smoking. His roommate smokes, so the smell still comes in the room and everything. He doesn't have his albuterol, they ran out. So obviously that's why they're having problems breathing now. And they come and see you. So what's your diagnosis? We already talked about acute asthma attack. What's the pathophysiology in the acute phase? So remember, it's a hypersensitivity reaction, smooth muscle contraction, mucus production, increased vascular permeability, so fluid, that water is going to leak out, airway edema. This is what an allergic asthma reaction is. Smooth muscle contraction, mucus production, and swelling. What were the causes? We talked about it already. No albuterol, and the smoke was the irritant. What is the significance of hypercapnia in a patient with asthma or an acute asthma attack? Why is the hypercapnia so important to look at? Why? Why is the CO2 building up? They can't breathe. So the worse that their breathing is, they've been having this asthma attack for a long period of time. Those accessory muscles to breathing can't hold you for a very long period of time. Eventually, these accessory muscles are going to stop working and they're going to fatigue out. When that happens, you can't breathe in and out very well anymore. CO2 is going to build up. You got to get rid of it. So when you have CO2 starting to build up, that means that that patient can't physically support their breathing anymore. You got to watch it. They may need to be intubated because they can't support their breathing anymore. Their CO2 is building up. They're going to crash and have problems. Say, I'm going to assign when that CO2 starts going up. And that's why, again, I made that comment about wheezing. Just because you have two people in a room, they both have acute asthma attack, one's wheezing, one's not, that does not mean that the person who's wheezing is worse than the one who's not. Because the one who's not wheezing, maybe their muscles just gave out and they're fatigued and they can't breathe anymore. That's why you're not wheezing, because air has to move to make the wheeze sound. Otherwise, you don't hear anything. So be careful with people who aren't breathing as audibly as they should. Now, acute asthma, what would the VQ ratio be with an acute asthma situation? This is a problem with airway or perfusion? Airway. So airway means it's going to be decreased. Okay? So if you decrease the ventilation, the VQ goes down. If you decrease the perfusion, the VQ goes up. Okay, that's it for the palm stuff. Moving on to derm. 25-year-old woman presents complaining of a rash that has developed over the last several weeks and seems to be progressing. On exam, you see several plaque-like lesions over the extensor surfaces of both upper and lower extremities. When you guys get into derm, really pay attention to what lesions affect the extensor surfaces versus the flexor surfaces. Some only affect the palms of your hands. Okay, if you have a hand, foot, mouth disease, as an example, you get ulcerations, breakout on your palms of your hands and the soles of your feet and in the mouth. But it's only where it shows up. So knowing where these lesions show up is also very important. Plaque-like, upper and lower, and she has them on her scalp. They're erythematous base with silvery scales and are demarcated very sharply. Okay. So what is your most likely diagnosis? Yep, and is this genetic, environmental, or both? This one is both. Family history and obviously your environment plays a role. So this is your psoriasis, silvery plaques. So make sure when you go through your studying, That's all there for you. I'm not going to repeat it now. But why do they have the plaques? Why do they have the scales? Why are they getting erythema? So this is all in your PowerPoints when you guys are studying. Make sure you know the difference. And what immunologic defects have been implicated in patients with this skin disorder? When they have psoriasis, what other things can they get? Well, I'm sorry. So the first thing was, remember, it's CD8 for psoriasis, and I think I mentioned something also. No, I guess not. Okay, that was it. So remember, they also can get psoriatic arthritis. And that's a seronegative. You'll get more into that later on when we get to ortho. So psoriatic arthritis is another manifestation of psoriasis. Okay, case 2. 35-year-old woman who recently returned from Africa presents to the clinic with complaints of rash to both arms that developed during the trip. Her meds: malarial prophylaxis, chloroquine, past medical history unremarkable, physical exam, small violaceous plaques on the flexor surfaces of the arms, angular borders, flat tops, minute white streaks are also noted. What's that known as? Wickham's striae. Okay, the little white streaks on top of those lesions. What's your most likely diagnosis for this one? Okay, this is your lichen planus, and the etiology is a side effect of the chloroquine. That was what the antimalarials can cause lichen planus as well. And what's the pathophysiologic mechanism that they're formed? We get infiltrate of T lymphocytes. Vacuoles appear because the inside is being destroyed. The T lymphocytes destroy those keratinocytes, so there's nothing left you have a void now because you destroyed all the cells inside. We get colloid bodies. They have these eosinophilic, and then obviously mature lesions, CD8s, are there as well. So what histopathologic changes in the skin are responsible for the appearance of these lesions as the purple striae with minute white stripes, dense infiltrate T lymphocytes, and vacuoles. So it's the same thing. The T lymphocytes cause that white striae. And vacuoles are here as well. Next one, 27-year-old woman presents to urgent care clinic complaining of a red, itchy rash on her arms and legs that developed suddenly the day before. So we know it's an acute onset. Rash is now spreading to her trunk. She denies any ulcers in her mouth or genital area. The fact that she denies any ulcers in the mouth or the genital area pretty much tells you, remember, what's special about those areas? They're mucosal, not skin. So this is only affecting the skin and not the mucosa. Okay. She has a past medical history for genital herpes. Last outbreak was 2 weeks ago. Meds, she's on acyclovir for the herpes. She did not take her acyclovir with her last bout as her prescription was expired. Physical exams, multiple erythematous plaques to the arms, legs, and should be and trunk, not 7 trunk. Because 7 and the and side are the same key. Lesions have a central area of duskiness. That means that the inside became necrosed. And that's why it's dusky compared to the red outside. Gives you those bullseye or target type lesions. No mucosal lesions are noted. Again, only the skin, not the mucosa. So is this an acute situation or a chronic one? This is acute. She has chronic underlying herpes, but she didn't take her medicine for it. However, we'll get to that part in a second. That does play a role. But the skin condition she's having for right now is an acute response. What's your most likely diagnosis? This is your erythema multiforme. Target type lesions. Erythema multiforme. What is the mechanism by which these lesions are formed? And which way is it similar to or different from lichens planus? Sparse inflammatory infiltrate versus dense infiltrate with lichens planus. Both contain your T lymphocytes are there as well. And widely distributed vacuoles versus vacuoles in the lower epidermis that you see with lichen planus. Have any more? Yeah. What factors may have triggered this rash? What are some underlying causes of erythema multiforme? Okay. She's got herpes simplex virus, HSV. And that's one of the causes. When that flares up, HSV can cause erythema multiforme. Now, patients are told with genital herpes they're on acyclovir chronically, but if they have a flare-up, they're supposed to take more of it to help with the outbreak. She didn't, or she ran out of her medication or expired. So again, HSV, herpes simplex virus, is what is one of the underlying causes for erythema multiforme. The target-like appearances, remember the inside inflammatory reaction and damage, and the inside is necrosed. And that gives you that dusky, paler appearance inside the lesion because the tissue is dead. 65-year-old male presents to the clinic complaining of blisters developing on his abdomen and extremities over the past week. Initially, they were red, and then followed by blister formation. They are pruritic, but not painful. No other complaints. Denies any mucous membrane involvement. Clinical picture is believed to be most consistent with bullous pemphigoid. What are the major differentials for multiple bullae? And how do these diseases differ? And why is this distinction important? So, bullous pemphigoid. Remember, the pemphigoid means it's not as severe as the pemphigus. Whereas pemphigus is intraepidermal vesiculation, worse prognosis. So bullous pemphigoid, bullous pemphigus are two of them. This one is pemphigoid, tense fluid-filled bullae with an erythematous base. So red base, bulla, those big blisters, very, very tight blisters, because they're filled to the brim with the fluid, skin's being stretched. And mechanism for the blister formation. Why does the blister form? What's causing it? Separation between the epidermis and the dermis. Separates out, fluid fills the area, and you get a blister. Case number 5, 45-year-old woman presents to the clinic with a rash on her legs for 2 months. Rash began soon after babysitting her niece who had strep throat. She also had a sore throat herself, which is alleviated after she took 2 days of antibiotics left over from a previous prescription. On the skin, anterior legs, several scattered, ill-defined erythematous nodules that are tender to palpation. And what's going on with this patient? Erythema nodosum, strep pharyngitis. Triggering stimulus was the strep underlying infection. She didn't have full dose of antibiotics. She only took 2 days worth, not the full 7 to 10 days you're supposed to. So the strep was still there, and it caused the reaction. What are some other causes? Sulfa drugs, oral contraceptives, and inflammatory bowel disease can also cause erythema nodosum. We talked about sarcoid as being another cause of erythema nodosum. These are the other ones as well. And the skin lesion formation, remember, it has to do with our subcutaneous fat. It's the only one that deals with the subcutaneous fat, is erythema nodosum. Everything else is the skin layers affecting it, but this one affects the subcutaneous layer. So you get fat necrosis, and that spreads to those subcutaneous lobules, and you get necrosis of all that. And histologic findings of the disease, fat necrosis, and inflamed fat septum. So just always with the subcutaneous fat layer is going to be erythema nodosum. 52-year-old African-American male presents to the clinic with a rash that has been worsening for several months, and he's got a chronic cough. On the skin, multiple red-brown dermis-based lesions, trunk, arms, and face, and several similar lesions are noted near the nares, okay, so near the nose. What's your most likely diagnosis based off of this one? Okay, I know you guys, it could be sarcoid, chest x-ray, looking at bronchoscopy, skin biopsy. This is going to be your, with the nasal folds, all the granulomas on their nose. Remember, as they breathe that in all the time and get into the lungs, causing that perihilar lymphadenopathy and lungs. Okay, perihilar lymphadenopathy. They're going to get that. Wider mediastinum. And histopathologic features of this disease, the granulomas are present in the dermis. They're not necrotic. They're just collection of tissue macrophages. And that gives you those lesions, the granulomas under the nose. I think that was it. Okay. So I know you guys didn't review a whole lot because you have other exams coming up, so as you start studying, hopefully this review will help. Otherwise, we're done with Unit 2. Now, after this unit, everything we learn from this class here on out, you won't do until next semester. So derm is the last thing that we do for this semester for CMS. We finish out neuro, endo, rheum, GI, and renal for the last sections. But those you don't do until CMS 2. That's only split in the class. Otherwise, you guys are set for the day. You guys have a long lunch break. See you guys tomorrow. No, you won't, okay, you guys see out tomorrow? No class? You cancel? You guys are at 2:30? Yeah, I won't be at work.